Hello, I'm Dr. Jim Rosso, a dermatologist in Las Vegas, Nevada, the current president of the American Acne and Rosacea Society, here to bring you from the AARS, from the president of the AARS, a commentary on rosacea. So recently, my colleague and also one of the board members of the AARS, Dr. Adam Friedman, did a very nice video on rosacea, and I wanted to dovetail on that and discuss one of the things that I think is really important, and it has to do when you initially see a patient with rosacea. And we recognize that patients with cutaneous rosacea can have ocular rosacea, right? That's always a possibility. And they can have phymas, especially rhinophyma, but you can have phymas in other areas, sometimes the jaw, sometimes a prominence on the mid-forehead area. But the rhinophyma, basically that proliferation on the nose makes it very bulbous, is the most common. But when you see patients with cutaneous rosacea, the vast majority fall into one of two types. They're central facial erythema, concentrated on the central portion of the face, that can fluctuate with greater intensity during flares, and then it gets quieter in between flares. That greater intensity happens due to an episodic vasodilation, and then it goes back to having a background erythema. If the patient has had rosacea long enough where they have a fixed baseline dilatation of their superficial vasculature over and above what it would be in someone that does not have rosacea, but then it could vasodilate even more during a flare-up. So that's what happens with that background of vascular erythema. And then they may or may not have what we call the inflammatory lesions, even though all of rosacea is inflammatory. They can have papules and pustules, occasionally one or two nodules, but really papules and pustules, absence of comedones. So when they have the diffuse central facial erythema, without papules and pustules, that was classically called erythematotelangiectatic rosacea. Erythema, along with telangiectasias, which all these patients typically have, right? Telangiectasias are fixed manifestations where the increased erythema with the vasodilation and the papules and pustules are transient. And then the diffuse background erythema that can be present even between flares, that is less than when they're vasodilated, but it's still there on the central face, that becomes a fixed component. So the transitory manifestations are the papules, pustules, and the increased central facial erythema during those episodes of vasodilation. So when we're seeing a patient that has papules and pustules with diffuse facial erythema, the erythema is not just from one source. First of all, they have increased transepidermal water loss in many cases. That leads to some changes that can increase erythema. But then you have the vasodilation over and above the fixed background erythema that these patients have, and then the erythema associated with the papules and pustules. And when they're coming in with all of that together, you can't really separate it out at that point. But if you treat the patients to get the papules and pustules to go away or go down significantly, you're going to get rid of the lesional and perilesional erythema associated with the papules and pustules. And that's really one of the easiest components of rosacea to treat fairly quickly, though it can take sometimes, a month or two to see a difference. And that's where we're utilizing our topical agents like metronidazole, azelaic acid, ivermectin, topical ivermectin. We have topical minocycline foam. We have other agents that the 5% microencapsulated benzoyl peroxide, which actually works extremely well and is very well tolerated if you're able to get access to that branded formulation, because that's the only one. So we have many topicals, and also we can use oral agents. We can use oral doxycycline or minocycline. We have FDA-approved formulations of doxycycline It's a low dose doxycycline. That's a sub-antimicrobial dose, so 40 milligram modified release. That's once a day. And now we have a low dose minocycline, which is specifically formulated in an extended release formulation that's specifically FDA approved for rosacea, and actually in a head-to-head comparison was shown to be superior in terms of reducing the papules and pustules, which is what these agents do, as compared to the sub-antimicrobial dose doxycycline. Now, we don't have enough data to say that that specific, and it's a branded formulation right now, it's not available generically, that specific lower dose of minocycline that's specifically approved for rosacea. We don't have enough data to say that it's truly subantimicrobial, but there is some preliminary data up front in the early portion of the studies to show that the microbiome was not specifically altered, but not enough to make that claim. And that claim is not made in the label. But that's another option that we have with those oral agents. Oral sarecycline, which is a weight-based dosing narrow spectrum tetracycline, there was a study that Leon Kursick and I did. It would be off-label. It's FDA approved for acne. But since it spares the GI tract in terms of having less activity against gram-negatives, at least initially, that could be advantageous. And it has a low rate of having problems such as gastrointestinal disturbance, vaginal yeast infections. It does not cross the blood-brain barrier, so you don't see vertigo. You don't see a lot of the reactions that we see sometimes with the tetracyclines, the GI upset, which we might see with doxycycline, or the dizziness or vertigo that you see with minocycline. And that's another oral therapy option. So we need to look at the patient, see what's going on at that point in time, and then, as Dr. Friedman went over, we target specific therapies to address individual manifestations. You may you're not likely going to be able to get to everything in the first visit. For the fixed background erythema, we have alpha agonists. For the flushing, he went over some low-dose clonidine and sometimes some beta blockers. Some of the data that we had seen on propranolol and nadolol, they actually don't seem to work all that well, but there are some other beta blockers, and especially for some data out of primarily Korea and other East Asian countries to show that carvedilol is one that can be helpful to address that increased erythema associated with the flushing. And remember, we have the alpha agonists that can address on a daily basis by causing vasodilation that increase background erythema. Telangiectasias are fixed. They are not going to respond to medical therapy. They're going to need a physical device, and we look at primarily pulsed dye laser or other lasers that can address telangiectasias, and also intense pulse light. Obviously, utilizing the right equipment in the right settings, and the devil's in the details. Having someone that actually knows how to treat these lesions with these devices is also very important. So that's my summary. Hopping on board my buddy Adam Friedman, and hopefully this helps you with regard to rosacea.